Hi, Galite. How are you?
Good. How are you?
I am well, thanks. Thanks so much for joining me here on these peer-to-peer videos. And I appreciate you taking the time out of your day in your workspace right there. Do you want to introduce yourself?
My name is Galite Hyams. I'm a speech language pathologist. I've been a speech language pathologist for a couple decades. I started in peds and now I randomly ended up in neuro in adult care. And I work in everywhere. They tease me, they call me the speech gypsy. And I actually work in and out of about six, seven facilities, sometimes random places. Pate rehabilitation is where I am today in Dallas, Texas.
Got it.
And I also work in various places in the Metroplex. I'm in Fort Worth today. I'm in Fort Worth,
Okay,
Texas.
great. And the whole purpose of these interviews is to, you know what, see if you can shed some light for the new learner or somebody who's struggling to figure out even before they take the class, how would I apply this in fill in the blank setting? And you being in a neuro setting is really a nice opportunity to kind of speak to that. Do you want to just give a brief background when you took the class, that sort of thing?
So I took the class in February, just this February of 2024, actually, and I kind of like just jumped right in. Now, I will give you a bit of a precursor that's saying it's not very common in North Texas. Manual therapy is not. I do have a colleague here that took your class actually in Austin, and it was like before COVID, and she is not a very hands-on kind of therapist. She's not a very touchy-feely person, and I'm kind of all over everyone. So for me, it was very natural. Um, and so her being familiar with the technique, she basically said, "Oh, I have someone. If you know manual therapy, I've got someone. Try this out. We've been doing everything aphonic." And I didn't really know how I was going to use it. I just knew that it needed to be part of my practice. Um, so, the, so the patient that she referred me was aphonic, had had two different strokes in various parts of the brain. He's since discharged. I don't have contact with him. In a wheelchair, had been in a wheelchair for a long time, non-ambulatory, but could be in a standing, could tolerate standing frame for half an hour. Um, And I started working with him, and they had suspicions that he had velopharyngeal incompetence. Um, but then I noticed some movement when he was laughing. So, of course, me and my curiosity, I started feeling around in there. And I will also tell you that this particular patient was refusing a fees. He was refusing an ENT visit to see if he did have VPI, and he was at that point refusing an MES, neuromuscular electrical stimulation. And he also had some religious beliefs related to surgical intervention that was not necessary. And so I started working with him, and it was almost creepy how needed that kinesthetic information. He needed those kinesthetic reinforcers, right? I personally can understand that. My choir director had stood behind me and grabbed my ponytail, pulling my head back to tell me what I needed to do with my alignment. And until she did that, it took me about 2 years to figure it out. So I can totally understand that. So a larger part of this piece, I feel, is the communication. And I feel that this technique and doing the courses with you and helping you in Alaska has changed the way I communicate and has helped a lot of the grad students that observe me change the communication. So, with this aphonic patient, I was able to really pinpoint, okay, what are you feeling? Where is sensation? Does this move? Does this not move? What happens if I put my finger here? Can you feel sensation? Can you Is it absence of sensation? And so just through working with him, and he was also a very spiritual guy, so it kind of combine it with some, okay, now imagine these structures moving. Imagine them moving to midline. Imagine them moving up. Imagine them moving down. Um, and he worked very, very hard on that piece. But the most amazing thing that I wasn't expecting, and now this is not an isolated thing, the most amazing thing was immediate change in facial symmetry, secondary to pterygoid release. I was like, the whole room was like, oh my gosh, like you're a witch. What did you do? And I think I have magical powers, but no, there's something in there, and we got at it. And no, it didn't stay. He needed multiple repetitions of that, and he eventually learned to kind of do it on his own. But I find it's pretty ubiquitous. Almost everybody that I work with that has facial paralysis, unilateral facial paralysis or paresis, there is at least a minimal increase in facial symmetry almost immediately when I get in there and work in there.
Does that then translate into, better ability for lip closure, for things like that?
Yes,
Have you seen that? Yep.
to all of it. Swallowing, food, bolus manipulation, laryngeal bolus control. Well, pharyngeal bolus control, but that all of those things. Yeah,
Great.
like aim in any of it because it's patient centered. So I'm not doing therapy at the patient. I'm doing therapy with the patient. And I think that's a big difference from a lot of the way that the culture that I'm in approaches therapy.
Right, right. And I think you alluded to something too that, you know, people who are not familiar with manual therapy, and sometimes even people who are learning it, but they're kind of new to it, it's still to many people about what we're doing to the tissues, fixing things in the tissues, which, you can't exclude that. But to me, I love the quote that's at the top of my Facebook page and now at the top of the new manual that everybody gets. It's touch. Manual therapy is just another form of communication. And the more of these different, rabbit holes we can give them to communicate with, sometimes it really resonates with a person, whereas other means didn't. And to me, it's never about this is better than anything. Everybody needs to be using this. I just think of this as one more really good quality way to potentially reach that person in front of you. And, that person-centered approach, that shared decision-making approach to me is how this work should be done. And not just this work, but like everything. Shared decision-making to me, it's the key. But I'm sorry, I'm taking away from your time.
No, no, I totally agree with you. This is a conversation. Um, yeah, communication. And I would like to see, I haven't seen any research, Walt, if you find anything, please let me know. Manual therapy versus NMES.
Mhm.
I would really like to see data because there are some things that I've been able to achieve with manual therapy
Mhm.
that what the goals have been written for with NMES.
Yeah.
And
Yeah.
just by playing. So,
Yeah.
can you,
I think that's a shame sometimes when goals are written so specific to the intervention, to the modality, if you will. Whereas, without the intervention, then the goal isn't applicable. To me, the goal should be an overriding functional goal, and how we go about that, the intervention shouldn't, it's just a part of our regular documentation, but not the goal itself. And, we had that discussion before, people talking about, well, should they include manual therapy in the goal? It's like, I don't think so at all. Other people believe it should. And getting to your first question, I don't know whether I've really ever seen any specific papers exactly, the neuromuscular or the electric stim versus manual therapy. It would certainly be an interesting paper, but again, we need that research. But how is it applied? How is the study done? That's what I look at. And I
yeah,
know there's the concept of people being in the center of their profession, where they stay within the group norms, whereas those who kind of work are comfortable out at the periphery. The more I teach this work to speech pathologists, the more I realize that a lot of people that come to my classes are very comfortable on the fringes, not necessarily feeling like you must apply a protocol strictly the way the study reads, but they're comfortable, inserting in their own experiences and coupling in the patient preferences and values. And that's where the people who are directly in the center say, well, no, that's not appropriate for manual therapy. But other people say, well, how much does it take to try it to see if there's an effect? That immediately lights on effect when sometimes we touch. I just think it's just a novel sensory input that goes up here for processing that may just change that motor outcome. And that's the way I look at manual therapy.
So now we might not agree on this, but I believe that it's neuroplasticity we're looking for. And
Yeah.
that, when I'm working with someone specifically that has lost sensation or lost movement, I have better skill with hypertonicity than hypotonicity.
Mm-hmm.
I've had better effects with that.
Yeah. Yeah. I neuroplasticity to me is more of a philosophical construct, right? Versus here's how you can see it and define it. Most of the research I've seen regarding neuroplasticity imply that it takes a bit of time for the nervous system, for the brain to reorganize in order to adapt to that, which is certainly a part of all the work we're doing, including manual therapy. But what I'm struck with sometimes is the almost instantaneous change in modification of the deficit or the function, that sort of thing. And I think that's where we get sort of a little messy. Is that neuroplasticity? Is that just, just awareness that was there? We just woke it up. I don't know. And maybe somebody who's better versed in, neurology and neuroscience could sort of correct me on that end. But I don't at all disagree that neuroplasticity is a strong element of what we're seeing as some of those outcomes, not just with neuro rehab, but in terms of some of the other, the functional things we work with throughout this work.
Yeah, I totally agree with and I appreciate being given the license to keep asking more and more questions.
Yeah, yeah.
So it's very
Well,
interesting.
yeah. What kind of? Oh, I'm sorry. Go ahead. You're chopping up. That's why I'm talking over you a little bit. I apologize. But did you have any struggles incorporating it?
Okay, so that's a very interesting question. I do work PRN in many different places, and it's culture dependent. Okay, and speech therapists, I'm not, you know, making a name for us, but some of us can be very territorial about our patients and write some very, very, very detailed notes of what they want us to be doing. But when a patient tells me I'm feeling pain here, everything goes out the window. And
Yeah.
so I've got I've been I've gotten some pushback from one facility that they no longer wish for me to return because I wasn't following plan of care. Even though technically it was, the therapist in reading my notes was not comfortable with, even though the notes were very good notes, it was kind of so foreign to them, even
Mm-hmm.
well documented, the patient's response, increased symmetry, increased range of motion, increased loudness, how the patient felt about the therapy. I was not asked to come back to that facility, and which is fine. I've got plenty of facilities that need me to come back. In fact, this facility here in Fort Worth, when I do come, even if I am covering for one specific therapist, they'll all rotate so that they can cover each other's caseloads to enable me to work only on manual therapy all day long with the patients that they're specifically referring
That's
me
great. Yeah, that's great.
to. It's
Yeah.
great. Any rapport with this. So here, and this is a day neuro facility. So there's two sides to it. There's like a residential side with the more severe cases, and then the day neuro. Once they graduate from that, they come to day neuro, and I find myself mostly working in day neuro here. When I work at Baylor, I work at Day Neuro also, and I found myself in the inpatient facility a lot. And so it's interesting. The patients that I work with in the inpatient facility now, they may not speak English. I may have a phone with me with an interpreter in Urdu or Korean or Vietnamese, a lot of Vietnamese patients. And some of them, if I see them multiple times, they're like, no, we don't need an interpreter. They just see me, they just take my hand and they just put it where they
Yeah.
and communication. But last week I worked with a patient that was in day neuro that I had seen in inpatient. And she was like, this therapist, she doesn't work with me. We just sit here and BS all day. My jaw hurts. And I'm like, oh, okay. So I get where that's coming from. And so I worked with her. And again, it's just such very different work.
Yeah.
It's
Yeah.
in
Two things come to mind. First of all, I asked you about your struggles, and a lot of times the struggle is that personal struggle of beginning to use it. It almost sounded like your struggles were more dealing with, because you're PRN, dealing with existing staff norms, etc. Is that correct?
yes, yes.
Yeah. Yeah.
That is my struggle. My struggle was, how do I document this? Like this is
Okay.
foreign to so many people that are reading my notes. They're like, what on earth is she talking about? Right?
Yeah. Yeah.
Heavily, heavily weigh my documentation on results, on increased range of motion, on patient reports, you know, release relief um in pain or whatever. And like we do pain scales a lot. And
Hmm.
so pain scales, and prior to treatment it's going to be a 1, you measure the pain, or say prior to treatment they say it's like a 6, and then after treatment they're reporting it's a 1. That's a really big deal that they have
Yeah.
an irritating headache. Okay, so maybe it's not my job to manage the headache, but it's very good data to see that difference. And so difficulty with using it. Okay, initially positioning, because a lot of the patients that I work with, they're in a wheelchair.
Hmm.
Okay, criteria. It's public. It's weird. I've got their tongue in my hand. We don't build. It might be the first time or last time I see them. I might be seeing them over and over again. There are some Mondays I wake up and I don't know where I'm working that week, but my week ends up being packed. So that's a struggle for me as a PRN therapist. And how do I get started? And we have some work to do. And I am surprised at how open a lot of patients end up being after just having my hands on their face for 30 seconds.
Hmm.
Anything you want, let's do this. And it's,
Yeah.
but my own positioning, today I had a patient's wheelchair locked and my right leg up on the wheel, and I'm like cranked over him, and then there's a desk. You got to work with that. I've been
Yeah.
spoiled situations where I actually have like an exam table and I can get them out of the wheelchair and have them lying down. Um, so for me, I think I am lucky in that I'm kind of an outlier as a speech therapist because I am kind of a fringe therapist at baseline. I have history of I've been a yoga teacher. I've done, yoga for singers workshops. And so I'm very comfortable with touch. I'm very comfortable with fringe therapy and
Right.
that joint therapy, but a lot of therapists are not. And it's very interesting to watch, and it's very interesting to work with graduate students that are just mind blown by the level of interaction. Like, wait, you're the therapist, you're supposed to be doing the therapy. Um, yeah, I don't know what else. I mean, I think supplies, right? Even today, I'm like, wait, I put my gauze somewhere. I don't have gauze. And I wasted 10 minutes looking for gauze.
Mhm.
That's right. Um,
Yeah.
say that if I were a very protocol based therapist, a very new therapist, really trying to do a good job, not having been introduced as a grad student to this sort of dynamic therapy, I think it would be pretty hard for me.
But
But
yet it's but yet it's fully covered in your scope of practice.
absolutely.
Yeah, I think that's what really throws people is because, just because it wasn't taught in grad school, or in sometimes based on my survey study that I just did really recently, some SLPs in grad school are told not to do manual therapy because of potential harm, risk of harm, which is okay. That's great for a basic safety measure. Don't do things you're not trained in. But to come away thinking that we should never touch because of the potential for harm, I just think is very sad that people exclude themselves, not just speech pathologists, but in general, even in physical therapy. Manual therapy has been devalued over the past 2 decades to be a low value intervention, passivity building, all those sorts of things, which it can be if not applied right, just like any modality or any intervention, right? I just think that sometimes just the value of affective touch, even if we're not doing something to the tissue, we're allowing this person to feel themselves worthy of being touched. It's safe to be touched, and that this person cares enough to look for different ways to interact with me. One of them might be touch, another one is all the other things you do. And just like I said earlier, to me, this is just one of many interventions that you might try with a person to see which one really turns on that light bulb.
Absolutely. Absolutely. And I think um, asking asking a patient about how something feels,
Mhm.
especially my patients have been touched in negative ways, in painful ways, in ways that are completely against um, their comfort level,
Yeah.
right? So by sort of gauging, okay, how comfortable does this feel? How safe does this feel?
Mhm.
That door to, oh my gosh, I have a say about my own body, like
Yeah.
bathroom by myself in six
Yeah.
months, sudden I have a say. And I
Yeah.
that actually creates a lot of buy-in because as therapists, what we struggle with is home exercise programs, doing their homework, oral motor exercises. And so when I think that that level of connection, that level of understanding, and I always say, I'm sorry, I don't have x-ray vision. If I did, I'd be working for the CIA. And they're like, oh, okay. I'm like, I'm not in your body. You need to tell me. I say all sorts of funny things. Your gummy worm analogy kind of gave me a license. But I think that really opens the door. And if there are caregivers present, they follow through with what I'm doing, secondary to, what the patient allows. And the whole family has buy in with the oral motor exercises. So
Yeah.
they see, I stick my finger in their face. There's increased facial symmetry, increased loudness. It's like this magician came in, and then I tell them, oh, how about you try these exercises? And they're like, okay, anything you say. They're just because they believe me at that point.
Yeah. Yeah. And I think it's so much more important to believe what they're feeling versus believe my words, because I don't know about your profession, but in my profession, a lot of the narrative comes from how we were taught, right? There's things in your body that you don't know about that I have secret access to that become part of almost like that cult like quality of the intervention, which we really need to stick away from. And I just think when they're understanding at the level that they can versus me trying to convince them of it, number one, the buy-in is better, and number two, it's so much more accurate. And we're not selling them a bunch of voodoo. We're selling them a reality-based type of outcome.
Yeah.
What about what about new clinicians who, any tips for somebody who's new to this or even considering this work?
So I hate to quote Nike, but my best advice is just do it.
Mhm.
Put your hands on someone's face, see how they react. You never know. They were,
Mhm.
I thought, and even other therapists were, oh, they're not going to want manual therapy. And they were like really obsessed with it at a certain point. So just do it.
Got it. You know, the other thing I get a lot, and I get a fair amount of it, and some of it is deserved, but my almost an avoidance of anatomical references when we do this work. Not that anatomy isn't important, but you know, somebody who's trained, okay, it's the masseter. Your masseter is in spasm. It's got whatever, right? And that concept of teaching from the perspective of anatomy, we need to lengthen that muscle, is something I learn, but I don't really embrace because we're treating a person's nervous system and not just that muscle. Did you have any difficulty, coming around to that, or is your outlier status to that was that easier?
So, I mean, we're not going to agree 100% on everything. And I've had a different experience with that. I like to throw in a little bit of anatomy.
Hmm.
So here's the function of what you're supposed to be doing with, how this machine works. And I do talk about the anatomy that I'm touching. Okay, my fingers on your pterygoids or whatever, wherever it is, those seem to
Hmm.
be. Um, and not that I'm insecure about it, but I think given the culture, it makes it more scientific and the
Hmm.
patient doing in the setting that I'm in a lot more. So I think there is a little bit more trust in my expertise when I'm not flaunting, but at least I demonstrate a little bit of knowledge in
Yeah.
that
Yeah.
balance, and you gotta not overdo it.
Right. And to me, when I'm working with a patient, that's exactly how it is. I give them enough anatomical medical type information to let them know that, okay, this guy's not a moron. He knows what he's doing. But then I also love, you know me at this point, I love to roll in uncertainty. Yeah, it could be that masseter, or it could be the nervous system that basically sends the message to that muscle itself. Um, can we ever really know? Maybe, maybe not. Is it as important as we think? In my book, it's not. Other people think it's incredibly important to know that origin insertion because that's the muscle in distress. I don't. I say this at every class. I don't want to say the anatomy doesn't matter, but which anatomy are you going to pick? Right? Are you going to, at least when we're really thinking at this at our own level? Is it the muscle, or is it the nervous system, or is it the person's fear, etc.? But by all means, I certainly voice to my patients it could be that muscle itself or give them a couple options, but then flip over to their lived experience. So you didn't have a big struggle with that.
No, no.
Good, good.
Yeah, again, I there's a lot of the fringe stuff I don't have a big struggle with. Um, I Yeah, I do agree with that, and I do say that. The hard part for me is when people are like, "What is this called again?"
Mhm.
And I'm like, "It's manual therapy," and they're like, "No, no, no, but what is it called? Like what you're doing?"
Mhm.
Explain it to you. Well, it used to be called myofascial release, but I can't be arrogant enough to say what I'm doing is releasing that one tissue, the fascia. There could be lymphatic drainage going on. There could be some neuromuscular retraining. There could
Yeah,
be hundreds of things going on. So to pinpoint it to one tissue doesn't make sense anymore. So,
yeah, yeah. The patients love brand names, and clinicians seem to love brand names even more. And you know what? Still trying to extricate myself from those words, myofascial release, after 4 years of officially like letting go of it. But if that's what the patient comes in and says, "I hear you do myofascial release," I say, "Yeah, we could talk about that later if you're interested." But I don't totally negate that for them because I don't know whether the conversation needs to be had at that point. If down the road, if it is important, we'll chat about it. Most of the time, it's like It's not at all. It's just, it's brand representation. We like to label things, and the patients are no different. So good. Um, Anything else you want to share? I don't want to keep you from your workday too long.
I feel like, oh, they knew this when I had the day off today, and I was like,
Okay.
we have a Zoom call at 11, so you're gonna have to give me some space for that. They're like, okay, fine, just come in.
Okay.
But
All right.
I don't know what it's, I feel like there's so much I want to share,
Yeah.
um, in this region, in this culture where really the work that we're doing is so foreign. Um, it's interesting, and the more graduate students I have that observe me or that I work with, because I do have to supervise various places, um, the more I'm wanting widespread use of more tools. So, like manual therapy. And I think that the
Yeah.
fact that she did so much is should be enough evidence for us to keep doing it.
Yeah.
Is tricky if you're not, it's for all patients and it's not for all therapists.
Mhm. Yeah. Absolutely.
But it's
All
great.
right. Thank you so much for taking some time out of your day today. And it was nice talking to you.
Likewise, be well.
Okay. You too.